Hello again. This is Kay Afchi again doing the online lecture for the Learning Plan Nursing Care of Patients with Alterations of the Endocrine System. In this section we're going to talk about the care of patients with diabetes and also the care of patients with hypoglycemia. Now, diabetes mellitus is actually a group of diseases in which there is a disturbance in the metabolism and use of glucose secondary to a malfunction of the beta cells of the pancreas. Again, just reviewing, the beta cells are responsible for making insulin, and because insulin is involved in the metabolism of carbohydrates, proteins, and fats, then diabetes mellitus is not limited to a disturbance of glucose homeostasis, but alters other body functions as well. If you take a look at page 860 in your textbook, there's a table 37-1 that discusses the clinical categories of diabetes mellitus and its characteristics. First, let's look at type 1 diabetes. This was formerly known as insulin-dependent diabetes, and it accounts for probably up to about 10% of all cases of diabetes. And type 1 occurs when the body's immune system destroys the insulin-producing beta cells. There really is no way to prevent type 1 diabetes. People who have type 1 will require injections of insulin to help with metabolism of glucose because they have little or no insulin being produced by the pancreas itself. Generally, people who have type 1 diabetes are quite prone to complications. Ketosis is associated with the excess production of ketone bodies because the body itself can't metabolize the blood in the glucose in the blood. It starts breaking down proteins and fats, which result in the production of ketones, and this leads to ketoacidosis, which actually is metabolic acidosis. Type 1 diabetes is more likely to develop early in life. It used to be called juvenile diabetes or ketosis-prone diabetes. Type 2 diabetes, formerly again called non-insulin dependent diabetes, makes up about 90 to 95% of all cases of diabetes. It's believed to begin with insulin resistance, so the patient's pancreas is still producing insulin, but the cells are becoming resistant. And so the interaction of the insulin with the glucose is less effective, and the glucose metabolism is abnormal. Type 2 diabetes usually occurs later on in life as opposed to type 1 that occurs early on. And the patients with type 2 rarely develop ketoacidosis because they do still have some insulin that is assisting with metabolism of blood glucose, so the body isn't prone to breaking down fats to get energy. Okay, then we have what's called latent autoimmune diabetes, which is a form of type 1 diabetes. It's also called a slow onset type 1 diabetes, and it's believed that there are islet cell antibodies in the blood that eventually destroy the beta cells in the pancreas, and insulin production eventually will be impaired if non-existent. Patients with latent autoimmune diabetes are usually not overweight, and they may have a family or personal history of having an autoimmune disease. The diagnosis is made based on, first of all, the onset after the age of 30 years. The islet cell antibodies are circulating in the blood, and insulin is not required sooner than 6 months after the diagnosis is made. Sometimes patients who have latent autoimmune diabetes are mistakenly diagnosed as having type 2 diabetes. And then we have gestational diabetes, and this occurs because of the stress of pregnancy. It can be treated with diet, oral hypoglycemic agents, or insulin. And after the baby is delivered, the patient should be reevaluated, because almost 60% of women with gestational diabetes can go on to develop type 2 diabetes. The baby also carries a risk of becoming or developing type 2 diabetes later in life. So factors that are associated with the development of type 1 and type 2 diabetes. Type 1 diabetes is a genetic predisposition. They may have had a previous infectious disease. As far as race goes, the type 1 diabetes occurs more commonly in whites. And there is oftentimes a presence of islet cell antibodies in the blood. In type 2 diabetes, usually patients are older in age, they are obese, they have a family history of type 2 diabetes, they may have a history of gestational diabetes, they have a history of impaired glucose metabolism. We also note that these patients are quite physically inactive, and there are more African American or Hispanic, Latino patients, and that occurs more often with this disease. Okay, so here in this slide we see the signs and symptoms of type 1 diabetes. The classic symptoms are related to the fact that the patient is suffering from extremely elevated blood glucose levels, otherwise known as hyperglycemia. And this increases the concentration of the circulating fluid volume and pulls water from the cells and the tissues into the blood. This results in cellular dehydration, loss of glucose, loss of electrolytes, and increased water excretion in the urine. The cellular dehydration then sends signals that cause the patient to become really thirsty, so the patients drink a lot more water. And then it also causes diuresis, which causes then, of course, increased urination. The hunger or polyphagia is a result of the body's effort to increase its supply of energy. Even though the intake of more carbohydrates doesn't really make the glucose available to the cells because of the missing insulin. Fatigue and muscular weakness occur because the glucose needed for energy is not being metabolized appropriately. And weight loss in patients who have type 1 diabetes occurs because of the loss of body fluid, and in the absence of sufficient insulin, the body begins to metabolize its own proteins and its fat. Because the metabolism of fats is not complete, fatty acids are converted to ketones and acetone. When the kidney isn't able to handle the accumulating ketones in the blood, that's when ketosis occurs, and then it results in ketoacidosis. The body also, in response to the dropping pH, so they're going into ketoacidosis, tries to balance that acid-base level by getting rid of acids. So they're going to maybe be experiencing nausea and vomiting, getting rid of hydrochloric acid in the stomach to try and balance out that pH. With type 2 diabetes, we find that about 80% of the patients who have type 2 diabetes are obese, and that there's a higher incidence of type 2 diabetes in people who are sedentary and eat a high-calorie diet. We do note that with weight reduction and increased physical activity, blood glucose can be restored to normal levels and maintained there. So when we're dealing with type 2 diabetics, we really need to stress the importance of diet and exercise in the management of the disease. People who develop type 2 diabetes may possibly be experiencing polydipsia, polyuria, and polyphagia, but more commonly seen is the excessive weight gain. Patients also usually have a family history of diabetes mellitus. You may see that they have a poorer healing of scratches, abrasions, and wounds, and quite frankly, even with type 1, we find that people with diabetes are prone to have infections, delayed wound healing, and vascular disease. Other symptoms of type 2, you might see the patient complain of blurred vision, itchiness, drowsiness, increased fatigue, and tingling and numbness in the feet. So classic signs and symptoms are like we said before, the polydipsia, the polyuria, and the polyphagia, as well as the fatigue and muscle weakness. You see weight loss in weight loss in the type 1 diabetic. You see weight gain in the type 2 diabetic, and both patients, type 1 and type 2, are prone to infection, delayed healing, and vascular disease. How do we diagnose diabetes? The American Diabetic Association recommends screening all adults for type 2 diabetes after the age of 45, and repeat that every 3 years. They recommend either drawing a hemoglobin A1C, a fasting plasma glucose, or a 2-hour glucose tolerance test to screen for diabetes. Okay, let's take a look at some of the diagnostic tests. This is from the American Diabetes Association website. And first of all, we'll look at the hemoglobin A1C. A normal hemoglobin A1C is less than 5.7%. A pre-diabetic would be diagnosed if it's greater than 5.7%, but less than 6.5%. Oops, that's funny. Excuse me for having that pop up. I don't know how that happened. Okay, so anyway, so the hemoglobin A1C, normal would be less than 5.7%. Pre-diabetic, greater than or equal to 5.7%, but less than 6.5%. And then we have diabetes is diagnosed on a hemoglobin A1C of greater than 6.5%. If we're looking at fasting glucose, a normal glucose is less than 100. Pre-diabetic would be greater than 100 or equal to 100 and less than 126. And diabetes would be diagnosed based on greater than or equal to 126 milligrams per deciliter blood glucose. And then for the glucose tolerance test, normal would be less than 140 milligrams. Pre-diabetic, greater than or equal to 140 or less than 200. And then greater than 200 milligrams per deciliter would be diabetic, or considered a diabetic glucose tolerance test. You wouldn't necessarily have to memorize the level for the glucose tolerance test, but you definitely want to realize what the abnormal hemoglobin A1C and the abnormal or diagnostic level for a fasting plasma glucose would be. Okay, so self-management of diabetes. We try to keep the patients within tight glycemic control, which means that we control the glucose within the normal ranges for people with both type 1 and type 2 diabetes. If we try to keep them within tight control, we find that the patients usually experience fewer complications. There are some risks associated with keeping the glucose levels in tight control, because especially with older patients, we find that they have a tendency to get too low, and we don't want the patients to experience hypoglycemia. So in some cases, tight glycemic control isn't possible. The overall goal of diabetes management is achieved when blood glucoses stay within normal limits. The hemoglobin A1C shows that the blood glucoses have stayed within normal limits, from one test to the next, which is usually every 3 to 6 months. And the patient's weight is maintained at a normal range, that the blood lipids remain within normal limits, and the patient themselves feel that they are healthy. Again, older adults will experience hypoglycemia more quickly than younger people, so again, they're not really candidates for tight hypoglycemic or tight glycemic control. You need to really monitor older patients for signs and symptoms of low blood glucose. Severe hypoglycemia in older adults can result in myocardial infarction, stroke, or seizures. So again, tight control is not necessarily appropriate for the older client. I believe the American Geriatric Association recommends that the hemoglobin A1C be at about an 8% for the older patient. Diet is the cornerstone of diabetic treatment. Weight gain is common with type 2 diabetics because of their high caloric intake and their decreased availability of endogenous insulin. So weight gain can make patients with type 2 diabetes even more insulin resistant. Type 2 diabetics can control their blood glucoses by reducing their caloric intake and increasing their physical activity. Again, the treatment for each diabetic is really individualized to the person, because diabetes is an unstable process. Usually our diabetics are managed by a registered dietitian or a certified diabetes educator, and they work with the individual based on their assessment, and they consider a range of interventions in designing a plan for the patient. Interventions may include reduced fat intake, carbohydrate counting, simplifying a meal plan, making healthy food choices, individualized meal planning strategies, the use of exchange lists, the use of insulin to carbohydrate ratios, which means that they adjust their insulin dose to match their carbohydrate intake. They also include interventions such as physical activity and behavioral strategies. The goal is to provide adequate nutrition with sufficient calories to maintain a normal body weight and also to control cholesterol so that the blood glucose can be kept within safe limits. Okay, and then exercise is also an important part of managing diabetes. Muscle activity improves glucose utilization for energy, and it also improves circulation. Exercise also makes the insulin receptors on cells more sensitive to the hormone and thus improves utilization of circulating glucose. Exercise has been shown to improve glycemic control in type 2 diabetics. The exercise program needs to be designed specifically for an individual patient. Again, the exercise programs should be or start out with a milder form of exercise and gradually increase until the patient's tolerance level is at the therapeutic effect that is desired. The program should not be started until the blood glucoses are under control. Preferably, exercise should be done the same time every day. Preferably, it should be done after a meal when the glucose levels are the highest. Blood glucoses should be checked before starting exercise. Patients should be encouraged to wear a medical alert bracelet when they are going out. And they also should inform their friends, if they're with their friend and they're working out, about the signs and symptoms and treatment of hypoglycemia. Managing the blood glucose levels during exercise is pretty much individualized to the patient, irregardless of whether or not they're type 1 or type 2. Gradually increase activities and consult with a healthcare provider for safe implementation of exercise program. Guidelines for safe exercise include knowing the blood glucose before exercise, and if the blood sugar is low, taking a carbohydrate snack of 20 to 40 grams based on the patient's body weight should be consumed before starting the exercise. Snacks during the activity should be used to prevent hypoglycemia, and the amount and frequency of the snacks should be determined by the type and duration of the exercise. And liquid or readily absorbed source of carbohydrate is recommended. If the person performs exercise when insulin or the oral anti-diabetic agent is at its peak of action, it can actually bring on an acute hypoglycemic reaction. So eating a piece of fruit before light exercise, if done between meals, can help to prevent hypoglycemia from occurring. Once the patient begins to follow a more regular exercise program, the insulin dosage and diet would need to be revised. Some patients may need to take less insulin and increase their caloric intake with regular exercise. So it's recommended that they keep a daily record of their exercise along with the weight, their insulin dosage, and their blood glucose levels. Oral hypoglycemic agents are usually prescribed for patients with type 2 diabetes to help manage their glucose levels. They are not a form of oral insulin. Actually, they are a completely different class of medications, and there are several major categories. If you look on page 865, there's a table 37-2 that lists all the oral glucose or oral hypoglycemic agents, where their site of action is, how they control their blood glucoses, and their other considerations. I'm not going to get into the specific ones because you've already had the class in pharmacology, but definitely take a look at those, as it's important that you know the difference between the different types of oral hypoglycemics. Okay, and then there's insulin therapy, and that can be prescribed for patients either who have type 1 or type 2 diabetes. And the goal of insulin therapy is to closely simulate insulin that's produced by the pancreas throughout the day. So what oftentimes you'll see is a patient will be started on a single dose of insulin in the morning, and that may be supplemented through the day based on the patient's blood sugar values, and that's noted as it's a sliding scale. I'm pretty sure you've probably talked about this in your pharmacology class, but if a patient's on a sliding scale, it's based on their fingerstick glucose results, and the patient then administers rapid-acting insulin before the meal, and then he eats right away. He shouldn't be taking rapid-acting insulin too far ahead of the meal, or he'll experience hypoglycemia. In the healthcare system, every time an insulin dose is drawn up, another nurse needs to verify the dose to make sure that it's correct. It's just a safety policy that's done throughout the healthcare field. Insulin itself can't be taken orally. It has to be injected. It can also be given via IV drip. If that be the case, insulin that's given IV drip the patient's carefully monitored, and the insulin that's used is rapid-acting or regular insulin. It's not a long-acting insulin. And then the patient has blood sugars done periodically, and then the dosage is changed based on those values. I'm not going to really get into too much about insulin, again, because you've had the pharmacology class, and that was covered in that prior course. So again, as a review, the goal of insulin therapy is to closely mimic the basal insulin that the patient has or should have normally. Patient may receive it via multiple daily injections, or they can receive their insulin via an insulin pump that delivers a continuous infusion of insulin based on the patient's blood sugars. It continuously delivers kind of a basal rate or a minimal rate to maintain the blood sugar levels between meals, and it can also be programmed to administer a bolus dose for meals or if elevated blood sugars occur. Then we also have insulin to carbohydrate ratio. The patient receives extensive MNT and needs to be taught to interpret blood glucose patterns and how to count carbohydrates, and also to calculate bolus doses based on carbohydrate intake. 1 unit of insulin will cover 15 grams of carbohydrate for most patients. If you look at table 37-4, page 867, they have an example of a lunch calculation for carb counting. And if the patient seems to be a candidate for that, then he or she would see a registered dietitian or the diabetic educator to set up that insulin to carbohydrate ratio program. There's also another category of medication excuse me, called incretin mimetics. Because they mimic the action of incretins, which are hormones that are released from the intestine, In type 2 diabetics, they tend to lower postprandial blood glucose levels, and that type of medication is discussed in your textbook on page 869, table 37-5, injectable hypoglycemic agents. And that table, it discusses how the medications treat diabetes via synthetic hormones. Although these medications are administered subcutaneously, none of them should ever be mixed in the same syringe as insulin. As some of you who have gone through clinical care management probably are aware, emotional and physical stress of surgery can often increase the blood glucose levels and also alter the amount of medication needed to control blood sugars. So patients with type 2 diabetes usually are taken off of oral hypoglycemic agents up to as much as 48 hours prior to surgery, and then they're started on insulin injections to achieve adequate control during the stressful period post-operatively. Patients may need reassurance that they're not going to be on insulin for the long term, but it's just a temporary intervention until they are able to eat and get back to their normal diet. Blood sugar determinations are performed quite frequently post-operatively. For all patients that have diabetes, IV fluids are begun as soon as the patient is ordered to be NPO, and then are continued until the patient is eating again after surgery. During surgery, patients may have an insulin infusion of regular or short-acting insulin, depending on how long the surgery is going to be. Blood glucose is monitored closely during surgery and then every 2 to 4 hours post-operatively. In this picture you can see the sites that are appropriate for injection of insulin, irregardless of whether they receive it in an insulin syringe or if they receive it in an insulin pen. These particular sites are appropriate for insulin administration. Here we have a picture of an insulin pump. There's a catheter that infuses the insulin subcutaneously into the patient's subcutaneous tissue. Again, the pump can read blood glucose values, etc., and then adjust the insulin infusion to maintain the blood sugars within normal range. Another intervention is islet cell and pancreas transplantation, and there are clinical trials underway to optimize procedure for the treatment of type 1 diabetes. Cells are taken from the donor pancreas and injected into the circulation of the hepatic system of the recipient, and these cells then lodge and start producing insulin. Lifelong immunosuppressive medications are needed to prevent rejection of the cells. And whole organ transplantation of pancreas can also be done to replace insulin function. As far as nursing management of diabetes goes, we do a lot as far as monitoring lab work, blood glucoses, hemoglobin A1Cs, fructosamine assays. We monitor for signs and symptoms of hypoglycemia, and we also monitor for signs of ketoacidosis. If you go to page 870, there's a table 37-6 that has the comparison of hypoglycemia and ketoacidosis. If you look at hypoglycemia, the etiology is it usually occurs as a result of overdose of insulin, a skipped or delayed meal, or unplanned strenuous exercise. And the symptoms of hypoglycemia are headache, weakness, hunger, pallor, irritability, lack of muscle coordination, apprehension, shakiness, diaphoresis with cool, clammy skin, blurred vision, rapid heart rate, confusion, and coma. The treatment for hypoglycemia is the patient should swallow either 3 glucose tabs or 6 ounces of juice or 6 ounces of regular soda or 8 ounces of 2% or skim milk or 6 to 8 lifesaver candies. If the patient cannot swallow, then glucagon should be administered IM. And if the patient's at the hospital, D50 in water solution should be given IV. To prevent hypoglycemia from happening, the patient should eat meals at least 4 to 5 hours, at most really 4 to 5 hours apart, plus prescribed snacks. They must make sure to take the correct dose of insulin, test their blood glucose levels regularly and even more frequently during illness, and eat extra food when exercising more than usual. For ketoacidosis, it results because of a failure to take prescribed insulin as a result of illness or infection, overeating or having too many calories or carbohydrates, severe stress related to surgery or trauma or emotional upset. Symptoms are increased thirst, increased urination, acetone or fruity smelling breath odor, dry mucous membranes and sunken eyeballs because of dehydration, nausea and vomiting, deep respirations known as Kussmaul respirations, so they're deep and rapid, abdominal pain and rigidity, paresthesia, weakness, paralysis, hypotension, a minimal urine output or no output at all is a late sign, as well as coma or stupor is a late sign. Treatment is IV fluid with insulin to correct the electrolyte imbalances, and in severe cases the patient is hospitalized until they're stable. Prevention is to take the correct dose of insulin, to consult a healthcare provider when ill, even for minor illnesses, and to follow a diet. Do not overeat and do not overload with carbohydrates. Things that we focus on for patient teaching. Again, we focus in on foot care because patients oftentimes have decreased sensation in their lower extremities. So if they're wearing ill-fitting shoes, they may develop blisters or corns that can later lead to open areas and decubitus, or ulcers, foot ulcers. So we want to prevent that from happening. So we want to make sure they perform good foot care. They examine their feet with a mirror to make sure that there's no injuries because they're not going to feel them. Then we're going to teach them what to do on sick days. Medication, they should take their insulin as prescribed and adjust the dosage as directed depending on blood glucose readings. If they're taking an oral hypoglycemic, they should take the usual dose, but do not increase the dose unless ordered to do so. If vomiting or unable to take the medication by mouth, then notify the healthcare provider. They may temporarily prescribe insulin. Try to eat a normal diet on schedule. If the patient complains of nausea or vomiting, replace carbohydrate solid foods in a normal diet with liquids that contain sugar such as fruit juices, regular soft drinks, or Jell-O. Take at least 1 cup of water or calorie-free, caffeine-free liquid each hour to decrease the likelihood of dehydration. Monitor blood glucose levels at least every 4 hours and record the result. And if severely ill, make sure to check the blood glucose every 2 hours. They should call the healthcare provider right away for vomiting and abdominal pain, or if the temperature is higher than 100.2 Fahrenheit. and notify the healthcare provider if blood glucose is higher than 200 milligrams per deciliter or if the urine test would show ketones. Report to the healthcare provider if the blood glucose level was higher than 200 milligrams per deciliter and does not come down with an additional dose of insulin. And if unable to reach the healthcare provider, it's recommended that the patient go to the hospital emergency department. If the patient is going to be going or traveling, then they're instructed to carry twice the medication or insulin that they are expected to need in case of travel delays, and to take copies of prescriptions along in case they need to refill them. Also, it's encouraged that they wear a medical alert bracelet or tag and carry medical information in their purse or wallet. It's recommended too that they carry an emergency supply of fast-acting sugar at all times in case of a hypoglycemic episode. Also, they should carry longer-acting foods such as peanut butter and crackers. They should pack dried fruit, nuts, and seeds as snacks because these are high in calories. Check your blood sugars frequently. Changes in time zones, eating, and activity levels can affect blood glucose levels. If you become ill while traveling, seek medical attention immediately. Stick to your prescribed meal plans as much as possible. Obtain sufficient rest and avoid stressful situations as much as possible. It's best to travel with someone who's familiar with diabetes and the treatment. And it's advisable to inform airline personnel about diabetes. Obtain the usual amount of exercise. Drink a glass of water every 2 hours to prevent dehydration. Protect the insulin from temperature extremes. Eat something at least every 4 hours. Call ahead to the airline or ship companies to request diabetic meals if necessary, or take your own. Before departure, research food substitutions and remember time zones and the changes in time zones. When you're working with an older adult who has diabetes, it's important to assess their hearing and vision and use appropriate aids. Set a time for teaching the session that is agreeable for the patient. Arrange a quiet environment. Be certain the patient is comfortable. Keep the sessions to a maximum of 15 to 20 minutes at a time. Limit information to a few major concepts. Go slowly and seek feedback that the patient understood what's being taught. Allow time for the patient to jot down important points. Repeat key concepts frequently. If the patient doesn't understand, try rephrasing the concepts. Use bold type print materials with a yellow or white background. And leave printed materials that are illustrated with simple drawings. And printed materials should be written at a 5th to 10th grade reading level depending on the patient. If the patient seems to become frustrated, stop the session and reschedule. And then summarize what has been taught and what has been learned at the end of the session. So short-term complications. When you're in doubt as to whether the patient is experiencing hyperglycemia or hypoglycemia, treatment for hypoglycemia is instituted until the blood glucose determination is obtained, because if the patient becomes hypoglycemic, then there's a chance that they could develop brain damage from an extremely low cerebral glucose level. Hypoglycemia usually occurs much more rapidly. Hyperglycemia usually develops slowly and does not have an immediate change in the level of consciousness, whereas hypoglycemia, the patient becomes extremely anxious and cold and clammy, and their symptoms occur much more rapidly. Another complication for patients who have type 2 diabetes is hyperglycemic hyperosmolar non-ketotic syndrome. It is experienced by type 2 diabetics who have high blood glucose levels because of illness or added stress such as an infection. So the glucose levels can be actually greater than 600 milligrams per deciliter, and in some cases can go well over 1,000 milligrams per deciliter. These high glucose levels cause severe dehydration and circulating fluid volume depletion because of osmotic diuresis. So blood osmolality is considerably elevated, so the patient is definitely much more dehydrated. The HHS is different from diabetic ketoacidosis because, again, the patient has a small amount of circulating insulin that's available, so there's no need to break down fats and proteins because the patient is still able to use some of the insulin in his body, as opposed to the diabetic type 1 who has no insulin, and therefore the body starts breaking down fats and proteins, which results in ketone byproducts, which results in ketoacidosis. So they're a little different between type 1 and type 2. The GI symptoms do not occur with a patient that has HHS. So they don't always seek medical attention until their course of illness has progressed quite a bit. So the patient's mental state is what you might see changing, and it'll progress from confusion to actually complete coma. And patients may experience generalized seizures as well. Things that precipitate HHS are medications that increase serum glucose or cause dehydration, such as steroids and thiazides. Secondly, acute illnesses such as infection or myocardial infarction or stroke can precipitate HHS. Chronic illness such as congestive heart failure and renal dysfunction can also cause HHS, as well as treatment such as total parenteral nutrition and peritoneal dialysis. Treatment of HHS focuses on fluid replacement and correction of electrolyte imbalances. Fluid replacement initially will be rapid, so you need to assess their cardiovascular and respiratory status frequently. Small amounts of insulin may be used also until the glucose levels are stabilized. Then we have what's called rebound hyperglycemia, and this is also known as Somogyi effect, and it follows a period of hypoglycemia, often during sleep. When hypoglycemia occurs, the body secretes glucagon, epinephrine, and cortisol to counteract the effects of low blood sugar. So the patient may report nightmares and night sweats, along with a morning elevated serum glucose. If the patient increases the insulin, it actually worsens the problem. The Somogyi effect is diagnosed by checking blood sugars during the night, and the usual treatment is to lower the insulin dosage or move the time of the intermediate acting insulin to bedtime. Also, changing or increasing a bedtime snack may be helpful. So the patient with a Somogyi effect is experiencing hypoglycemia during the night. And because that happens then with the secretion of the cortisol to counteract the effects of the low blood sugar, the patient will be experiencing extremely high blood sugar in the morning. The dawn phenomena is characterized by an elevated glucose in the morning. It's caused by the release of growth hormone, glucagon, and epinephrine during the night as the body's natural circadian rhythm. The dawn phenomenon is the reason why many people with diabetes do not tolerate carbohydrates well in the morning, and the treatment for it is an intermediate acting insulin at night. Here we have a picture of a blood glucose monitor. The patient pokes his finger and applies the drop to the strip that's inserted into the machine, and the machine then will give us the result of the blood sugar. Long-term complications as a result of diabetes. First of all, cardiovascular disease is caused by damage to the small and large blood vessels. The elevated blood glucose levels over years seriously damages the blood vessels and the organs that they serve. Two out of 3 people with diabetes die prematurely from heart attack or stroke. The Joint Commission core measures recommend aggressive measures be taken to prevent stroke in patients at risk. So tight glycemic control is the best strategy to prevent myocardial infarction and stroke. Peripheral vascular disease, often gangrene, occurs because of the impaired circulation, and this can often lead to amputation. And this is far more common in patients who have diabetes. Vascular changes typically cause very poor circulation in the feet and lower extremities, and healing of wounds in those areas is extremely difficult because of the poor blood supply. Nephropathy often occurs because of changes in the renal blood circulation. Factors that influence whether a person with diabetes will develop kidney disease includes genetics, blood glucose levels, and blood pressure. Nephropathy can be delayed or possibly prevented by, again, keeping tight control of blood glucose. Retinopathy, otherwise which causes visual impairment and blindness, is common in diabetes mellitus. The 3 most common problems are diabetic retinopathy, cataracts, and glaucoma. Diabetic neuropathy occurs in approximately 70% of people who have diabetes. It primarily affects the peripheral nerves that can cause sexual impotence in man, constipation, neurogenic bladder, pain or anesthesia in the lower extremities. Again, it's good reason for foot care and daily inspection of the feet, because the patient often cannot feel cuts or blisters or abrasions on the foot, and that neglected sore can eventually become infected. Okay, any conditions that affect the intestines, liver, and pancreas can lead to hypoglycemia. Examples are like diabetes mellitus, gastrectomies, and surgical bypass procedures. Tumors of the pancreas, liver disease, and disorders of the adrenal cortex and pituitary gland can also produce abnormally low blood glucose levels. People who abuse alcohol or other substances are also prone to hypoglycemia. The signs and symptoms we kind of covered, but we'll go over it again. Rapid heartbeat, tremulousness, weakness, anxiety, nervousness, and hunger. Symptoms occur suddenly within 4 hours after a meal is eaten. And some physiological symptoms can sometimes be mistaken for psychiatric illnesses. There may be symptoms of irritability, temper tantrums, personality changes, etc. Diagnosis is made based on the measurement of blood glucose values, and this patient's insulin levels and C-peptide levels can also be measured. A CT or ultrasound may be used if they suspect an insulin-secreting tumor. Hypoglycemia is treated by modifying eating patterns. Smaller and more frequent meals that are relatively free of simple sugars are recommended. The diet should be high in protein and low in carbohydrates. Carbohydrates should be complex ones, such as those found in whole fruits, vegetables, and whole grains. Refined sugar and white flour are omitted. Complications of hypoglycemia. If left untreated, hypoglycemia can lead to a shortage of glucose in the brain, which can possibly lead to death. Healthy People 2020 have a major objective in increasing the proportion of persons with diabetes to receive formal diabetic education. And nurses play a crucial role in home care and in teaching the older population about diabetes. Long-term care nurses must be alert to the signs of diabetes, and home care and clinic nurses should be persistent in assessing compliance with diabetic regimens and also participate in diabetic teaching.